Greetings and welcome everyone to another episode on Oral Pathology 360's Oral Pathology Tuesdays. This time we are going to be talking about Candida and oral cancer. This is a topic that has been going around for the last 60 years since it was first described. And it is very important, of course, because without knowing the exact pathogenesis, management is always a problem. And to be able to do this, we have with us today three outstanding uh, experts from different parts of the world. Sorry. And interestingly enough, I have met every one of them because of their work on oral cancer. We have with us Professor Jos Hille. He has more than 36 years of 3 decades of experience in oral and maxillofacial pathology. And if you have attended anything on oral cancer, you will normally find him there, especially in the last 3 years where we have been a lot online. We have constantly seen him. He has a personal interest in oral cancer and is very active in this work. Then we have with us Professor W.M. Tilakratne. He is also very well known, of course, and he's a senior consultant. He's an ex-president of our association. He is in the top 2% of researchers in the world by Stanford University's list. If you think about any work on oral cancer, you will always find him there, and that is how much earlier on I found him was because of his work and because, of course, we always cite his work. We have also with us Dr. Jeronimo Lazos from Argentine, and he is an oral medicine in the mix. Basically, he brings us the clinical view and the clinical outlook. He also has done a lot of work on oral cancer, and he has been also on the channel like both the others before. And again, the topics was on oral cancer, and they are adding to our knowledge today. And we hope to see today's discussion. Of course, I can't say that we are going to have a final answer to whether Candida is in a causative role as far as oral cancer goes, but we will definitely have a better picture of what is happening and where our state of knowledge is today. So let me welcome, yes, welcome to all of you all. It is wonderful to have you with us today. Thank you for
Good
joining.
morning. Good morning. How are you, Mandana?
I'm fine, thank you.
Prof.
How are
Tilak?
you?
Morning, good morning.
Yes, we seem to have temporarily lost Professor Joss. We shall,
Yes. I am not seeing him
yes,
now, but
this is all the wonders of this is one
yes,
wonder of the virtual world. In
of
the
the
real world,
of
you don't lose your speakers last minute.
oh, it can happen. A
Yeah,
quick trip to the bathroom sometimes.
yes, that is true. So, yes, hello, Dr. Nasser. Nice you could join us.
Good morning, Dr.
So,
Nasser.
yes, so yeah, I'm going to just tell everybody that since I have a cold, I may be
Yes.
turning off my video and my mic off in between, but I will be there and I will definitely be a part of this. Another thing, just to remind everyone, there is a poll
Mm.
that has been posted. Please respond to that. It is to see how much you believe or what you believe, your personal belief, because obviously we each have our own belief as to whether oral cancer is related or not related with candida. So, with that, let's dive in. What is going to be our first thing? We are going to be talking in the next hour or so. We are going to discuss four concepts and then we are going to move on with your questions and answers. So, please remember to type in the chat. The first thing we would like to know is, we would like to talk about is, as of today, in a historical way, if we had to go through, what would you we say, and from your personal experience, is the connection between candida and oral cancer? So I think I will just go with Professor Joss first, and then after that, we can continue with building on whatever he says, and then we will just go on with the questions.
Hello, can you hear me, everybody?
Yes.
Yes, yes, yes.
Wonderful. Good day to everybody. Good morning, evening, night, afternoon. Thank you, Mandana. This was the question: does Candida have a causal relationship with oral cancer formation? And when I was starting in my career, we were actually looking at the relationship between the possibility of hyperplastic candidiasis, which can show severe pseudoepitheliomatous hyperplasia and progression into cancer. Did a study actually on about 50 patients where I initially found that there were 3 cases which were equivocal in terms of whether there would be early cancers or early invasive cancers or not, but we didn't have access to P53 and all these other markers. And it showed that of those 3 cases, we treated them with antifungal therapy systemically, and the lesions reverted to normal. I must say that they were all lesions from the tongue, and we also know that the dorsum of the tongue is not really a predilection site for oral cancer formation. Whether I would say pseudoepitheliomatous hyperplasia associated with hyperplastic candidiasis is mostly found, especially in the dorsum of the tongue. So there's a few clinical issues there that do not quite correlate. But I don't think that anybody has ever lost the idea that because Canada is so ubiquitous and also preferentially colonizes abnormal epithelium or diseased epithelium, that there might be some kind of coexisting role in either the propagation or even of oral cancer in the presence of other carcinogenic factors. There are some various models now that have been showing that in vitro, as a matter of fact, oral Candida infection does indeed seem to be associated with oral cancer progression. But where there is no, at the moment, if I can be corrected, unequivocal evidence that there is progression from dysplasia into oral cancer in the presence of Candida infection. We do know that Candida infection does make oral dysplasia look in the microscope a little more severe. And we know that if we treat the oral Candida, the dysplasia usually get a microscopic, more quieter picture. So I would say at the moment what is evident is that yes, there is chemical interactions of Candida with the epithelium. There are nitrosamines that are being formed. There are other carcinogenic factors. There is excitation of interleukins, which are inflammatory markers. But and also there's even been evidence now that P53, but that is the wild type, is increased in lesions that are infected with Candida. But I have not been able to find any control of dysplasia that are not infected with Candida. But it seems that P53 wild type expression is increased when Candida is present in, let's say, lesions that we now call oral potential malignant disorders. So yeah, that's where we stand at the moment. I think that we haven't at all lost the interest in the putative influence of Candida in the oral dysbiome when there is cancer present. And I think that when it is present, it may be because of the fact that the dysbiome is created by a difference in the immunity related to the patient that also could predispose to cancer progression or not. So there's a lot of factors that are, I would say, they're in parallel in the putative role of Candida infection and oral cancer. But I think that at the moment, that what stands for sure is that oral cancer can progress faster or quicker in the presence of the normal carcinogens, but when Candida is present, it does not seem. It does seem that there is probably an enhanced influence on the cancer. But the progression from oral dysplasia with cancer infection into oral cancer itself, that has been proven.
Right. I guess. Okay. So, Professor Tilakratne, you want to add something to that from your experience?
Yes, this. Thanks, Mandana. Thanks, Jos. Uh, as we all know, this is an issue that we have been discussing over the last 3-4 decades. Now, what are the main questions that we ask? Is Candida actually carcinogenic? If yes, what are the mechanisms? Then, do we have enough evidence in terms of laboratory research and also prospective clinical research to convince ourselves that Candida is actually carcinogenic? Now, the answer for all these three questions, yes and no. We do not have definite answers for these questions. That is the very reason why still there is a group of people who believes Candida has a carcinogenic role, whereas another large group of people do not believe Candida is primarily carcinogenic. Now, as you all are aware, now if you look at the 2022 WHO OPMD list, chronic candidiasis has been removed. Why did we remove it? We removed it simply because we do not have strong research, especially to show the connection between Candida and oral carcinogenesis in terms of laboratory research mostly. True, we have factors here and there. Now, there are a couple of reviews came early last year or so. They describe the mechanisms which are probably playing a role. But again, the mechanisms that they describe using other papers, they are not in-depth clinical research. So that is where the problem is. Now, one of the reviews is, it's a fairly good one in the Journal of Pathophysiology. The systematic review came from Norini et al. They have tried to explain or describe all the mechanisms associated with, at least the described mechanisms, superficially at least. But over the years, we know few of the things time to time people describe. We know there is Candida associate aldehyde dehydrogenase 1 is increased when there is Candida. So we know the role of ADH1 in converting ethanol to acetaldehyde. We know acetaldehyde is a known carcinogen, and it has been shown in a couple of studies that acetaldehyde is more in oral cancer with Candida than oral leukoplakia and oral lichen planus with Candida. So that superficial evidence suggests that there could be some role, but whether it is an association or cofactor or the causality, evidence is not strong enough. Now, again, if you look at some of the things like stratifene, that is encoded by SMN gene, and it is a regulator of mitotic translation. A couple of papers shows that stratifin is also increased in candida-associated lesions. Now, there are isolated papers describing various other carcinogenesis-related enzymes and molecules, especially proteinases, then, of course, increased lipolytic activity and phospholytic activity, etc. And also, some people believe that Candida has the ability to produce nitrosamines by the conversion of nitrites and nitrates into nitrosamines. Of course, one of the things that fairly convincing is the conversion of alcohol to acetaldehyde. So likewise, there are various things that people have suggested. As Jos correctly said, uh, most of the evidence that people believe Candida has a role to play in carcinogenesis, that is oral carcinogenesis, is the increased colonization of Candida in these lesions. That, especially the OAD, the oral epithelial dysplasia leading to cancer, this, there is very, very strong association of Candida colonization in those. But that connection, as I said earlier, is not confirmed, or the studies in order to identify that connection, especially in terms of prospective studies, is lacking. So that is where the problem is. So if in addition, if we look at our real life, in practicality when we report, now in my experience over the last 30 years, about 20 to 30% of our dysplasia cases are infected with Candida. But if you look at the oral epithelial dysplasia transformation rate, is not that much. But we know something for a fact. When we look at oral epithelial dysplasia section with candidal superinfection, now most of the dysplastic features, at least some of the dysplastic features, are exaggerated, very prominent. To mention a few, like increase the number and also the prominence of nucleoli. It's a very prominent feature when there is candidal infection. And suprabasal mitosis. Those are cytological features frequently associated with the candidal infection. But if you look at the other side of the coin, the architectural disturbances, yes, the chronic hyplastic candidiasis and chronic candidal lesions have architectural disturbances, especially in terms of keratinization. So there are features, but one thing that our young clinicians, pathologists should know, whenever it is infected, your case is infected with Candida, unless you treat with Candida and do a second biopsy and get the definitive dysplasia grading from the pathologist, don't take drastic actions, especially in order to go for surgical intervention. I usually, in my practice, do not give a grading of dysplasia when there is candidal hyphae on the surface. We always say there is cytological atypia, but give a course of antifungal and do a rebiopsy after a month or so. Then, as again Jos Hille correctly said, when we get the second biopsy, most of the features have disappeared. So whether there is a connection to carcinogenesis is something that we need to think in that context. But again, why these features are reversible? What is the mechanism? Now, that aspect the research are missing. So that is one of the reasons why, because we are not convinced whether this is definitely carcinogenic. So, but I'm in agreement with a lot of people that there are some attributes, as I mentioned earlier. Candida may have some attributes to oral carcinogenesis, but until such time we have more solid and concrete data, we decided to remove chronic candidiasis from OPMD list. I'm sure it will make a comeback once we have more and more research.
Yeah.
We are not hearing you, Mandana. You are mute.
Yes. Now this is something I'm going to keep forgetting to unmute myself. Okay.
Don't worry.
So uh, we have been, first I said thank you, Professor Tilakratne, for that. And we have been running a poll on YouTube. The question was, does Canada play a role in oral cancer? So far, 33 have voted. Out of that, 73% have said yes, 3% have said no, and 24% have said not sure. Now we'll see if the number changes as we go ahead. Now, coming back, so Ronimo, you want to add anything to what has been said so far, and then we will go towards actual discussion after that.
Okay, so after, besides what Dr. Josh and Dr. Tilakarakne have said of the the actual mechanisms that may allow candida to induce or to facilitate malignant transformation, such as Prof. Tilakarakne has mentioned the production of acetaldehyde, that uh, production of acetaldehyde has also been suggested by means of the biofilm, not only in relation to candida, the production of nitrosamines, but also in recent times, I'm, I'm guessing like 15 to 10 years ago, candidalysin, a peptide toxins that is produced mainly for the pathogenic forms of yeast, pathogenic forms of candidiasis, has been shown to interact with epidermal growth factors, in, increasing cell proliferation, epithelial cell proliferation. Also, in addition, upregulation of pro-inflammatory cytokines may promote cell proliferation and also inhibit apoptosis. So, I believe that the chronic inflammation associated with a state of disease of chronic candidiasis may also um, promote or ease the malignant transformation because of the host cell activations, the neutrophil recruitment, and the upregulation of interleukin 17 that has been shown also in association with candidiasis. So there are many, as Professor Shaw said, putative mechanisms that an infection, let's be clear on that, we are talking about a chronic infection, not a long, persisting, uh, enduring infection, not something that it happens for a short burst of time. So, uh, the, all those mechanisms can can be associated with malignant transformation, but as Professor Tilak Karakten say, we there's just no enough amount of credible and good study that may explain totally as to how, if candida is associating or is easing malignant transformation. From the clinical standpoint, it also has been said that both clinically and sometimes also when you take a biopsy, it's sometimes really hard to distinguish between lesions that are white and red in a patient that maybe has some viral gene, has a lot of biofilm present, and maybe also has some habits as such as smoking that all can help to produce candidiasis. It's very hard to say sentence in a patient when there's candidiasis that's playing a big role in modifying the clinical feature of a given lesion, and when you don't, and when you have candida affecting that lesion, to what extent. So what we do in our oral medicine service when we see a patient with oral PMDND, oral potential malignant disorder, or in fact, when we see a patient with oral squamous cell carcinoma, and that particular patient has a set of factors being local, gene, lots of plaque, lots of biofilm, and being systemic, maybe the patient is an uncontrolled diabetic or something of the sort. So when we have a red and white lesion with a lot of inflammation, with a lot of erythema, and the lesion is activated, we always do what we like to call to basic oral medicine therapy, that we remove all sources of inflammation. That accounts for chronic mechanical irritation, for doing a really good basic periodontal therapy, and sometimes we also use antifungals to reduce the inflammation and then to assess the patient. As Professor Character say, we may, if the patient has a lot of inflammatory background and candidiasis may produce that, we may hold off the biopsy until we have kind of reduced the inflammation, and for that we tend to use antifungals to treat that. But it has to be said, it's sometimes it's not clear whether the candidate has been secondary to the OPMD, or it has been a part of the growing of the enlargement of the lesion. We just don't know.
Thank you, Professor Lazos. So, we had a good discussion so far, and I think uh, two things that we need to clarify. One is, so in terms of the possible mechanisms that we have, when we think of it, it's is there a, of course, there is chronic inflammation is always something we talk about, and then immune responses, genetic mutations, and the pro-inflammatory environment. So, in these four mechanisms that have been suggested as a cause or for the role, for a carcinogenic role, do we have, do you think we have enough proof for any of these? Let me ask Professor Tilakratne first.
Yeah. Yeah, it's a good question. Yeah, this is where the problem is. You are very correct. Now, the three or four mechanisms that you mentioned, those are probably the mechanisms, if at all, the candida is taking part in oral carcinogenesis. Now, as I said earlier, one of the main associations is the adherence of candida to the epithelium. Now, the chronic adherence, chronic contact of any microorganism and their products like enzymes and endotoxins, etc., can trigger the various signaling pathways which are implicated in chronic inflammation, cell proliferation, survival, etc. So that can lead to not only to those processes, that can lead to uh, overstimulation of these signaling pathways can lead to trigger mutations. So that is a possibility. So yes, the chronic inflammation can come in different ways. This is one of the ways in which the chronic inflammation can set in. In addition to that, the mutations, yes, the as you said, yes, you can get, but we know little convincing metabolite that we are talking about in terms of candidal carcinogenesis, acetaldehyde. Jeronimo also mentioned about it. Now, acetaldehyde, we know if we look at it in general, it can bind to protein and DNA, changing their structure and function. So that is a well-known thing. Whether there is enough amount of acetaldehyde, depending on the severity, etc., of dysplasia, uh, that line of research is lacking. we know in general, we say, the acetaldehyde, when it is produced in the presence of candida, can change the DNA structure and function, and also various other protein products. But again, there is not much of evidence. And another thing, that acetaldehyde and various other things which are implicated in candidiasis can reduce the antioxidant activity of things like glutathione. We know glutathione is a main antioxidant. What happens when the body's antioxidant mechanisms are reduced? You get increased amount of reactive oxygen species. I don't need to explain you the role of reactive oxygen species, and also inflammation in carcinogenesis in general. So yes, there are factors coming here and there, but only thing is, as I repeatedly said, that connection, especially in terms of prospective clinical research, is lacking. So that is where the problem is. And also, the Jeronimo, I think, mentioned about this new enzyme called candidalysin. Yes, the people are talking about it because candidalysin can induce epithelial damage. So that epithelial damage can induce chronic inflammation in the oral mucosa and the epithelium. Because we know that can induce or upregulated inflammatory pathways like MAP kinase, NF-kappa B, etc. So that, yes, that enzyme, it is a new thing, newest toxin that people are talking about in terms of candida. Yes, but what we need is, now we know a lot of data, a lot of things. It may play a role. That is how we say. But that definite connection has to be made. So that is the task of the young scientists and researchers, to look into this in great lengths, not just superficial research in order to publish just a paper, but to be involved in. I think the best way to go forward is to have multi-center the collaborations, to have a very large cohort of patients having candida and various degrees of dysplasia, and to investigate these mechanisms, whether they are real or they are just. Now, if you look at the reality, the most of these things come from either epidemiological studies and descriptive studies. They are not rock hard scientific studies, most of them. So that is where the problem is. Yes, as Mandana correctly said, those mechanisms, we have various loops to those mechanisms, but only thing is, we have not been investigating those things uh, in enough depth.
Okay.
So we are basically still at the association. We can only prove association and not causality. Yes, Professor Jos, please.
Okay, so I think that let's look, why do we have carcinogenesis? And we on various points, and you actually very quickly said very beginning. Okay, so we do know that in true carcinogenesis of oral cancer, we do have mutations, all right? And those mutations, they can vary, but we know more or less it's a multi-step pathway, but sort of have identified the kind of common mutations that occur in oral squamous cell carcinoma, and probably most of them are associated with with tobacco use, and maybe with synergism of alcohol. Now, do we have the evidence that the presence of Candida albicans can cause mutations on its own? If it cannot cause mutations on its own, can it cause conditions where we have epigenetic modifications or methylation that can vary the expression of genes and in an indirect way contribute to accelerated cell cycle and all the other hallmarks of cancer? We don't have that evidence. I'm pretty sure that the concomitant presence of Candida and patients who do smoke and also drink or both probably has got I would say, stimulatory role in the progression of the cancer. that I don't think is beyond doubt, because, as being correctly said, if we treat some of these cancers with anti-inflammatories and antifungals, which I also do, and antibiotics before we actually take a biopsy, we see that those lesions tend to shrink a little bit and tend to actually become a little bit quieter. I think the crux is the jump from dysplasia to invasion, and that is where we need to find what actually causes that jump. Is it in animal models? They've actually shown that on its own they can create cancers, certainly in the presence of Candida alone. But we have not seen a translation from animal models to human models. That's impossible. But I think we all agree. We all agree that the presence of Candida does influence the clinical as well as histological, and probably more so in dysplasia from a histological point of view, the morphology. And we tend to associate severe dysplasia or exacerbated features of dysplasia with a high risk of cancer development. We even have shown now that in differentiated dysplasia, you can get oral cancer formation. So that also is being turned a little bit upside down. But I think so far, what people are prepared to say is that yes, Candida can be a factor if it is deep chronic inflammation in the presence of other carcinogens. And those carcinogens are usually smoking and tobacco. We haven't actually seen any evidence of co-infection of HPV in Candida, which is another interesting part. But I don't think that's a completely different mechanism of carcinogenesis. So, but my question is, will we ever see the proof that the presence of Candida leads to a certain mutation in carcinogenic cells? And if not, is there proof of epigenetic that, that can take place? Those epigenetic places changes can be explained by all the other factors: inflammation, patient's state of immunity, this oral dysbiome, etc., etc. We know that the oral microbiome does change in the presence of a cancer. We know that, but to what extent we really haven't got to find the details. So until such time, as we all said, I think we need to be careful. We need to eliminate the possibility, but to really say that Candida infection on its own itself causes cancer, I think that the evidence doesn't really at the moment exist. It doesn't mean that its co-presence is nevertheless dangerous. And I think that in some patients it does play a role. But the thing is that if you think about it, Candida is ubiquitous. Candida inflammation is ubiquitous. We see so many patients, we see it in denture rates. Why don't they develop oral cancer of the pelvis when they have a chronic denture candida stomatitis? You got to think about all these things. Where is that clinical evidence? And we know there are many patients that have got dentures and got a chronic oral candidiasis. So if on its own, it would at some stage at least, we would see carcinogenesis in patients who are denture wearers and maybe no other factors. So it's as I said, I think we need to be just always on our guard and make sure that the patients are Candida free when we treat them or when we diagnose them.
Thank you. So let's take some comments from the audience and then we will continue with the discussion. We
Okay.
have Dr. Daftari with us. Good evening, sir. He has commented from our extensive TIFR study, Candida only induces keratinolytic, produces extensive parakeratosis with possible dysplastic changes. There's a combination, okay. but it is reversible with antifungal therapy. And they have found that no cancer from the long perspective as far as the TIFR study goes. So I guess there is agreement with that. Anything to add to
Mhm.
that?
Well, sorry, go ahead, Professor Tilak.
Go ahead, Jeronimo.
Um, a lot has been said about reactive dysplasia, where we have a lot of inflammation going on, and whether it is true dysplasia or some reactive dysplasia that can be reversed, in this case using antifungal therapy. Uh, Whether it's the egg of the chicken first, the dysplasia, then the inflammation, or the inflammation, then the dysplasia, what we can say that if an inflammatory state is sustained long enough, it can certainly affect the epithelial behavior, the epigenetic makeup of a epithelium and mucosal barrier. For instance, my PhD thesis was about epigenetic changes associated to chronic mechanical irritation, and it can be shown that those changes, if, in this particular case, hypermethylation of two particular genes, can be produced by chronic mechanical irritation. That is a factor that it's not known for causing, it's unable to produce mutations, but if it can silence a gene through epigenetic mechanisms, that may be the way that enhances malignant transformation. As to Candida, it can be, as Professor Josh say, that maybe there are other ways that we don't know yet that can the candida is using to enhance malignant transformation. Also, it has to be said that recent studies on the oral microbiome suggested that maybe there is complex interaction between bacterial and fungal communities that may promote cancer development, such as decreased fungal diversity and that is abundance of certain fungi. We always say that Candida albicans is the most common, but it has been proven that in some studies in oral patients and patients with oral potential malignant disorders, some other subspecies of Candida, such as Hanaella, Giberata, and Crusade, has been produced in large quantities. All in all the evidence that is present so far is circumstantial. We just don't know, but I think it would be prudent to treat our oral cancer, not oral potential malignant disorder patients, having that in mind, because oral cancer is multifactorial, and the factors that we know as today, uh, tobacco and alcohol consumptions, are can explain all the cancer. So there might be other factors in some patients, at least, that can be uh, facilitating or can be promoting malignant transformation. That's it.
Right. Anything to
Yeah,
Mm.
add?
I agree with Dr. Dinesh Dapri. Hi, Dr. Dinesh.
Hello,
Nice to
doctor.
see you. Always coming to these meetings. It's
Yes.
a good example for younger generation of people. Yeah, I agree with you, Dinesh, because we also have done a long term study, long time back though, looking at chronic hyplastic candidiasis and what happens after treating with antifungals. Yeah, true. The significant number of cases we did not have a lesion to do the second biopsy. So that after antifungal treatment, that is the reality. That is true. Another scientific question that we need to ask when we talk about candida and oral carcinogenesis is that whether candida act as an initiator or facilitator or just a bystander. The people are talking about this. I have seen one paper in PLoS Pathogens asking the question, is Candida albicans an opportunistic oncogenic pathogen? Good question to address. Uh, but we can answer part of it with the literature available now. Uh, some facts to believe for those people who believe it, uh, whether Candida is an initiator. Why we have to believe, at least to some extent, Candida has the inherent ability, according to some papers, to produce endogenous nitrosamines. So, is that enough threshold to progress oral carcinogenesis? That we don't know. And the production of acetaldehyde, we have been telling this over and over. We know the role of acetaldehyde in carcinogens. It can bind to DNA and protein adducts uh, that can damage the normal replication of DNA and causing various mutations and also chromosomal aberrations. So it can lead to both genetic and epigenetic changes. So that part is there. So for us to believe whether it is initiated, but those people who do not believe that, uh, whether we can find ways in which it facilitates. So those are the things that we need to answer and not answered at all at the moment. So therefore, yes, there are a lot of unanswered questions. As I said, now this kind of webinar should be used not just to hear something from few people, but this should be used as a good platform for networking and collaboration for multi-center studies, etc. I hope those who are listening, the younger generation of researchers, would take this message, and because we need to solve this, we can't be asking this question over and over. We have been doing this for last three to 4 decades. So because we are now in terms of molecular facilities developed up to the maximum. So therefore, the researchers should be able to find answers, because this is not a very difficult, tough question to answer. Uh, but only thing is the priority. So the priority should come, because we would like to see the definite yes or no in terms of chronic hyplastic candidiasis being an OPMD or not.
True. So we'll go on with the next. Good evening, Dr. Subodh. So we have his comment is candidiasis may not be directly responsible for OPMD or OSCC. However, presence of candidiasis in the mouth may indicate compromised health status of the patient, leading to development of oral squamous cell carcinoma. And I think everyone is already in agreement with that.
Yeah,
So I'll
yes,
just
he's
go.
correct. We have been, all three of us have been telling over and over the
Yes.
connection between the candida and the chronic inflammation, and also we have evidence to say it can suppress the immunity uh, by producing more T17, I think, cells, and also Tregs that can induce carcinogenesis by reducing the immune surveillance. Yes, that's no argument. So that is there, but as we have been telling over and over, what we don't have is the connection,
Hmm.
Yes.
scientific connection. That is.
Yes. We will,
Okay.
after we finish with the comments, we will end with your suggestions on what sort of studies people should do to get those answers. We will just finish the comments first. Okay, then we
Go
have a
on.
comment from Dr. Nasser. Even if we ignore disbelief nitrosamine theory, we cannot ignore the always inflamed environment. And yes, he continues. As beautifully mentioned, even histo changes, dysplasia to dysplasia like changes would be taken into consideration. I think this is again in sort of continuation of what we have been saying. There is an always, yes. Okay. So thank you, Dr. Nasser. Now we have one more here from Dr. Daniels. In OSCC arising from Candida leukoplakia, could there be a possibility that actually the candidiasis is a superimposed infection on an already established OPMD leukoplakia?
Of
Yes, I
course.
can see the nodding. Yes, I guess everyone is in total agreement. That is very clear. And
One thing, if you allow me, the recent position paper by the World Health Organization position paper, but by Dr. Saman, Roland Kursulisha, and many other experts, leading world leading experts. Um, um, in that article is beautifully stated as to why they take out chronic candidal hyperplasia of oral potential malignant disorder. They quote systematic review by Shukla and by, I think it was 2019, that studies specifically candida leukoplakia, and there were three studies mentioned that quote percentage of malignant transformation of such lesions range being for 2.5 to 28.7, and the group stated finally that that wide range of malignant transformation implies inconsistent diagnostic criteria, and that for me would be the first thing to take into account when studying malignant transformation. There should be a clear cut, recognized definition as to how to identify why there is candidiasis, then to maybe able to study. This position paper says that all the evidence that there is up to now is circumstantial, and there are studies where they use a right approach have an inconsistency of how to define candidiasis. So that's a problem up to now where the studies there is a lot of inconsistency as to how to define oral candidiasis.
this was a good question. I also wonder if it is candidiasis, then can we call it leukoplakia?
We've dropped that term.
Because if it's, I mean, this you can clarify when I have a doubt suddenly in my mind. Because uh, typically, leukoplakia is if you have ruled out everything else.
That's
But
right.
oral candidiasis is an existing condition. So if we are saying that it's candidiasis, then can we call it leukoplakia? Or we have to first rule out, or rather treat
Candida.
the candidiasis and then decide?
Yes.
Yeah, the term candidal leukoplakia and chronic hyplastic candidiasis people use more or less synonymously.
Yes.
Uh, so it's, but most of some people believe the term candidal leukoplakia should be used for pre-existing leukoplakia which is superinfected with by candida. But true, we have the some histopathological features to suggest it is chronic hyplastic candidiasis, not probably, possibly not superinfected the candida for a pre-existing leukoplakia. If you look at chronic hyplastic candidiasis, the things like test tube-like ridges, on top of that there is the the significant ketonization, basal area showing mitosis, etc. Those are features to suggest it is chronic hyplastic candidiasis, but they're not clear cut. But most people use this candida leukoplakia and chronic hyplastic candidiasis alternatively for the same thing.
Yes.
So terminology wise, also there are gaps.
I guess it will be practically impossible at the time of biopsy to say which was first. Was the leukoplakia first or was the
Mm.
candidiasis first? That
If
would
we
be
haven't
very
seen the patient
complicated. But
before, yes, it's It's
Yeah.
not possible. You
But
can.
one, yeah. But one thing, but it is not true for all the cases. The candidal superinfection, in most cases, I think Jeronimo knows well, being a clinician, with our clinical experience in addition to our pathology exposure, I know when you follow up a patient with the homogeneous leukoplakia for many months or years. Now,
Mhm.
one fine day, your patient can come to your clinic with red and white lesion, right? So then it could be one of the two things in most cases. Either it is genuine malignant transformation or it could be candidal superinfection. In
Yes.
that way, the clinician have some idea, yes, I had a homogeneous leukoplakia, but when the pathologist report, it is not chronic hypoplastic candidiasis, it is candidal superinfection. Yeah, but it doesn't work for all the cases.
True. So in some ways, I wonder if when we say, that um, compromised patient, immunologically compromised patients are prone to candidiasis, otherwise no. So instead of an entire patient, when we think of the patient being having immunologically compromised status, just the tissue being compromised, as would happen in the lack of shedding that happens in keratosis with leukoplakia, the increasing thickness and the reduction in the natural shedding. So can it be that if just the tissue is, I would say, immunologically compromised, so then there can be also candidiasis, that specific tissue, like you said, after a long time where there has been leukoplakia, and now there is candidiasis superimposed on that.
Mm.
Just a thought.
Well, yeah, these are all possibilities. Yeah, I'm quite interested in what Dr. Daftari actually says that there's a number of oral cancer with no habits. Yes, we know, and that is where obviously there is the outbreak. But
There we
notice
are.
we have just closed the loop on chronic irritation, so that it becomes narrow and narrow in terms of what are the real causative factors of oral cancer. Um, and I would like to see, I would really like to see some molecular evidence of when the presence of Candida in a lesion. And at the moment, we have got much to our disposal, but we do have P53 and Ki67. We know that P53 and Ki67 are elevated in chronic candidal infections and also maybe superimposed leukoplakias. Again, this is where the question is, if we see an increased P53, what is it due to? Is it a mutational P53 expression, or is it a co-expression of and wild type P53 and mutated P53? That is something that I would like to see solved. We do know that P53 is increased in lesions with Candida infection, but we cannot actually tell if it's wild type or it's a mutated type. But I think that I would like to see, does Candida infection cause loss of heterozygosity in the P53 mutation? That would be quite, an indicator that it would actually be uh, carcinogenic or co-carcinogenic.
Right. I'm going to
But how are we going to
request
do
you
that?
to keep these comments about what we would like to see for the end. We will do a rapid summary because we are running short of time. We'll answer just a couple of questions. Dr. Daniels is asking, can you comment on the risk of OPMD or OSCC development in liver cirrhosis or failure patients with candidiasis compared to normal counterparts?
No comments. I have no experience.
Anyone can comment?
I have no experience. I can talk about candidiasis patients, oral potential malignant disorder, and oral cancer, but with cirrhosis, liver failure, and oral cancer, I don't have experience. I
Okay,
don't.
so we are going to leave that open. And Dr. Daftari this is a continuation of his comment, and he says Candida can be superimposed. Today, you see a number of oral cancers with no habits. which is very true.
No habits. Yeah.
Yes. So those still are, we are looking for answers in those. Dr. Elisa says, so what do you suggest to be standard to help in optimal management of such situation, where this is where the candidiasis and the leukoplakia are together? Is it biopsy?
No, the interesting question. Now, whenever you suspect candida in a lesion, a pre-existing lesion, don't do a biopsy to start with. Do a smear. Do a smear. That is something very simple, non-invasive. Do a smear. That pathologist should be able to say whether there is candida or not, and if is candida positive, give a course of antifungal and do a biopsy to get the correct grading of dysplasia.
This is the best way to do it. Is liquid-based cytology. It's very, very sensitive for candida.
Yes, and if you want to learn more about that, Dr. Joss has a whole lecture on the channel that you can find and watch.
Yeah. So I do agree. You do a smear, but do a smear that liquid-based cytology, because it takes out all the inflammatory all the necrotic debris and blood debris and things like that, and you get a very clean, beautiful uh, print of the situation. And that's how I use. It's a very sensitive diagnosis of candida. And on top of that, you can use a PAP and a PAS, and at the same time, you can look to see if there's any dysplastic cells as well. Though, if you do a proper
Right. I think we have lost
For
Professor
now,
Joss.
Professor Josh.
He's
Yes.
gone. Okay, so we have one last comment from Dr. Subodh, who says, let us have a high suspicious index. Anything abnormal in the mouth is OPMBO or a squamous cell carcinoma, and is ruled out. Very true. And okay, so can we have those wrapping up comments? Because, like Professor Tilak very correctly said, is that the idea is to go ahead and be able to do more and overcome these shortcomings which have stopped us really reaching a decision. Because this is a time actually where more and more organs, it's being found that fungi are a possible participant in the cancer of those organs. Constantly there is uh, literature that is coming out, and and we are actually, oral cancers were among the oldest that were identified with in relation to candida. So I think it's time we settle this. So can we have a quick wrap up from each of you as to what is your suggestion with what would be the proper way to do the studies? We'll go with Professor Tilak Ratna first, since he's just finished the WHO book.
Yes.
Congratulations.
Yes. Now the yeah, I have been telling over and over the lack of research in this field. Now, how to do research in this field, to get the real connection, it is not easy. Because if you want to see the real impact of candida in oral carcinogenesis, if you want to do a prospective clinical study, then you need to have a set of patients, uh, various groups. For example, leukoplakia without any dysplasia, leukoplakia without candidiasis, without candida and dysplasia. Uh, that kind of groups, and you do all kinds of things that we mentioned earlier, whether to identify the things that we mentioned are actually real or not. But only problem when it comes to a human study, once you diagnose that the patient has candida, can you leave that patient for a long time without treatment? You can't. Ethical issues. In the past, probably people have done that kind of studies, uh, like the periodontal disease study that was done in Sri Lanka, the very famous study. Once you can't do that now. Once you diagnose something, you have to treat. So therefore, that obstacle is there. What is the alternative? To go for animal model, right? Can you produce the cancers and also the OPMDs or precancerous lesions, leukoplakias, etc. At least these plastic lesions in animal model, and have one group without candida, another group infected with candida, and see all these changes, what's happening. Uh, so it's not easy, but it is doable. So that is the way forward, I think, if you want to see the real connection between candida and oral carcinogenesis.
Thank you. Thank you, sir.
Mm.
Yes, Dr. Jeronimo, anything you want to add to what
Oh
we have
yes,
said?
yes, the study of uh, most or potentially malignant disorders and related factor is kind of hard to do now, because when you study such things such as candidiasis, that there is a can be present in really a lot of cases, it's hard to control the confounding factors and then really be able to say when a given factor, in this case candidiasis, has has a lot of support or not in the association that we are trying to prove or disprove. One thing I think that is really important, that it is really important to have a consistency in the way that we define candidal hyperplasia on candidiasis, and also, and that is also being said by the WHO, that antifungal treatment should be a part of the diagnostic process in order to see if the candidate also has an impact on the lesion. But we know that candidal superinfection can change the way the clinical phenotype of a lesion produces. So I think in our clinic we should be aware that Candida can indeed alter and modify an OAPMD. So we should be aware and treat it, as Professor Tilakranakta said. If we can, if we identify a patient who may have a lesion and also candidiasis, we should treat them both. So in our clinic, we do that as a part of a protocol with all oral cancer or oral potentially malignant disorder. We treat inflammation sources first, and then we assess the patient and some time later to indeed do a biopsy if that's required, or maybe more than one biopsy. But first, we treat sources of inflammation first, including candidiasis. But I think that's a difficult uh, topic to approach, to study. Really difficult.
Right. Thank you. Anyway, Professor Joss is still not there. So, yeah, we have this last comment. It's more a comment. In the cases of oral squamous cell carcinoma, occurrence of Candida albicans was seen to be in 36.7% of cases. That is, shows Candida albicans is usually associated with oral squamous cell carcinoma. This is from Dr. Vicky Gupta. Yes, I guess that again says there is association. Right. I think we have lots of association there. We still don't have the what the WHO would require to add it in the book. Sir, I'm a little interested, just before we wrap up, what have you included in your own book, Dr. Tilak Ratne?
Sorry,
Your own
say
book
it
is
again.
just out. I said your own book is just out. And what did you include in your own book?
Yeah, we have a chapter on candidiasis, but we have not specifically said this directly. But yes, similar to what is there in the literature, we have again, not strongly, we have just suggested vaguely, because when we removed chronic candidiasis this time from the OPMD list, we had a lot of discussions whether we should do it or not. But finally, we decided it should not be there, because information that we have is, compared to other lesions, is very vague. Even lesions like lichen planus also, it's the other debatable thing, because some people don't like to accept that it is precancerous or PMD, but some people do. If you ask me, my personal view, I do believe lichen planus transform into cancer, but very, very rarely, not to the extent that people think.
So for the audience, Sir's book has been just out, I think, about just a couple of months back. I will put a
Yeah.
link in the description so you can go check it out afterwards. And we had that poll going. Let me just tell you what happened by the time we are ending. So now we have 62 votes. 71% say Candida plays a role in oral cancer. 13% say no, and 16% say not sure. So the number of people who say it plays a role is sort of staying the same, although the votes have gone up now. Right. So, and Professor Joss has joined us from LinkedIn, I mean, from YouTube, because he's lost the connection here. Okay, thank you. Right. And Dr. Maria, I guess, is saying that Professor Joss could not be heard. I will try and add in a transcript to this video in a couple of days so you can at least read what was said. I mean, that's the best that we can do. Sorry for that. And with that, anything else any of you would want to say, or can we wrap up?
You can wrap up, I think.
Wrap up, yes. Okay. So, yes, thank you so much, all of you, for being with us, for your wonderful insights on this. This is a very interesting topic and ongoing, of course. I hope it's a little more clear to everybody today as to where we are right now. And then we can hope that it will be clearer much very soon with all the youngsters working on it. And I would like to thank the audience for being here. Thank you, everybody from around the world. And yes, with that, I say thank you all. See you all again. Thank you for being here. Bye.
Be well.
Yes.
Take care.
Yeah,
We
we
will
thank
keep.
you.
We will keep studying. We will keep
Yes. Yes,
studying.
keep up the work. We can have you all back when we have the answer in place. Right. So next week's program is going to be on oral squamous cell carcinoma, sample dissection and reporting by Dr. Puyan Amini Shakib. I hope you will all join us. This is, of course, very dedicated pathology, which is also shown by the fact that there is only a microscope and no CT scan in that logo down there. So, yes, this is for us oral pathologists, and I hope you will join us. Thank you again, everybody. Have a wonderful week and meet you soon.